Good evening, everyone. Just checking first that you can hear me. Great. Well, I'm sorry that the scale is a little off. I do feel very large in the room there, but so happy to be with you all and very glad to be able to be part of this, even though I couldn't be with you in Delhi. And really lovely to know that there are a lot of current and former colleagues in the room with you. So wishing you an excellent conversation and a lovely dinner after this. Yeah, so thank you for the topic, Svea, and I think that community engagement or community participation or empowerment, or there's so many terms I think that get used in different ways that different stakeholders have very specific meanings for them, and we could get hung up on that. But I think that you're absolutely right. I think there's a recognition that we will not be able to achieve universal health coverage. We will not be successful in adapting primary health care delivery, service delivery to different contexts if we don't have communities engaged, and specifically women, whether it's through women's groups, whether it's mothers, whether it's female community health workers, that's absolutely essential. And so if we're looking at what's happening currently within WHO and in terms of the health policy and systems research discussion around the Alliance at the moment, I think there's a recognition that, this is a moment for primary health care as an approach, as a movement, as a vehicle towards the Sustainable Development Goals, particularly universal health coverage targets. And so, and we've been thinking about this for a long time. Of course, there are some exemplary examples across India, one of which that continues to come up throughout the history of primary healthcare certainly is the Comprehensive Rural Health Project at Jamkhed, but there are many other organizations that have been doing this work across the country for decades and of course across the world. And I think what we're seeing and what we're really trying to grapple with, and would really actually love input from colleagues in the room, and looking forward to continuing to work with many stakeholders in India on this question, is we have a lot of local sort of examples of a pretty comprehensive and well-developed approach to engage with communities, and that usually involves a sort of multi-sectoral opportunities for community support, community input, and really investing in communities, including women's groups, including youth resources, including microfinance or other economic development opportunities, educational programs, access to health services in the home, in first level health facilities. It oftentimes, the ones that have sustained, the ones that have really sort of worked with communities to identify what their priorities are and take those forward, do have a multi-sectoral bent, which I think is often a challenge for health systems and for programs coming that are wanting to contribute to health outcomes in a community. How do we effectively engage with those other sectors, understand the sort of multi-sector impact, and also really understanding how communities experience the package of services that is coming to them, which may or may not be very sort of well organized, and the collective impact that all of those services have on communities. So I think we're actually in the process of trying to better articulate and refine a research agenda, both for the Alliance as well as in collaboration with the Special Program on Primary Health Care at WHO. And the community engagement piece has been identified both through an evaluation recently of the special program, as well as through some conversations recently and over the past few years within the Alliance. So it's something that we're really hoping that we can bring to bear a few different kinds of tools, including looking at digital platforms, utilizing whether it's AI or other approaches to really taking advantage of all of the different data sources that are out there in order to better understand what is going on, who's being reached, who's not, and how we might be able to bridge some of those gaps. Obviously, finding better ways to support communities as the burden of non-communicable diseases continues to rise. And then also really trying to do a better job of teasing out what is the impact of community engagement, as well as primary health care more broadly as an approach, both in terms of universal health coverage as well as more broadly on sort of well-being. So I'm happy to come into the conversation further, but would love to hear from other colleagues. So back to you, Svea. Thank you.
Yeah, thanks, Meike. You question, but then also, Meike, as you said, there's so much unknown about what do we actually know, what actually happens, what's actually working. Yeah, so Devaki, I'm wondering if you could talk a bit about this at the regional level. Are there lessons or models that have been adapted or should be
Okay, so I'm, I'm slightly ill-prepared for the sort of the starting point of community engagement per se, and this is silly because we've done a number of witness seminars, very deep data collection on this just 2 years ago with people who had been closely involved with the National Rural Health Mission's community processes, including community-based monitoring, which was mentioned, and a number of other mechanisms. So let me sort of dive into that and try to talk a little bit about the regional context as well. I think for me, a lot of it is vexed and dilemmatic. So I'll present that to you, and I think you've had that kind of day, so perhaps it's apropos for me to continue that. Another thing I should say is that I'm speaking in my capacity, my personal capacity as an opinionated Hopkins alum, not representing my organization. So please bear that in mind. Yeah, in November of last year, at the regional committee meeting, the Delhi Declaration was proclaimed, which actually sought to, among many things, also emphasize social participation for health, which is one of these umbrella terms that includes community engagement, community action, various other forms of community voice and representation. So I'm going to start by just reading what the Delhi Declaration says and then start to make a mess of it. So the 2023 Delhi Declaration calls says that member states should, quote, institutionalize social participation by creating mechanisms, structure, space, platforms, and capacities for enhancement of community engagement in agenda setting, policy formulation, design of implementation and monitoring, and active involvement in primary health care service delivery. So as you can imagine, there are various models of various combinations of this throughout the region and certainly within India as well. So there is a large legacy that even a declaration like this comes from. But that said, for me, there is something vexatious about calling something community engagement because, and I think, Meike, you pointed to this also, there's a definitional issue here for sure. I think a lot of groups that have been working in this space for a long time would argue that community engagement automatically suggests an invited space. And so the balance of power there is quite clearly one in which governments are inviting you to engage with them over items of agenda that they decide. So I think per se deciding which domain of agenda setting communities are involved with is slightly problematic. And I say this even in the case of Thailand, which is actually leading the charge in terms of, and they've in fact, they're looking to table a resolution on social participation for health at the 77th World Health Assembly this May. And they, along with Slovenia and some other national governments, are really trying to lead this. But even the National Health Assembly, which is much lauded, much written about, is actually an invited space, right? And when you look at community action for health at subnational levels, quite often in particular contexts like HIV/AIDS mobilization, those are claimed spaces. Those are in many ways different processes, and there is this dilemma in my mind about how do you square that with this invited spaces approach, right? I think the other thing that other couple of things that I will raise is about what the spaces are physically and socially where this agenda setting, delivery of services, decision making can take place. Quite often when you look at this from an equity perspective, they are not accessible, right? So there can be challenges quite literally with respect to where physically some of these types of meetings, assemblies, engagements are held, which do not allow people to sit shoulder to shoulder, people to even access those spaces, depending on what their situation may be. Whether they are migrants, persons of different ethnicity or caste, or the So I think that that then is related to the other issue in the Delhi Declaration, which is about capacities. And again, a little vexed because on the one hand, we do want to call for institutionalization of social participation, which would insinuate that the government takes the charge in enhancing these capacities. But isn't that somewhat problematic in the first instance, where capacities should come, where is the community power coming from if it is subject to those kinds of processes? And what about the legacies of civil society and other community formations leading the charge and building capacities on our own, right? And claiming spaces, saying nothing about us without us, right? So I think for us, even as I'm part of a collective, actually it's called Svea, that is advocating for institutionalization of social participation for health. Globally, we have case studies across regions, and a lot to learn from what's happened in India. And in fact, there are so many examples. I'll maybe quickly talk about them and then hand over to Somesh. I think as we move forward, to me, perhaps the opportunity is in kind of teasing apart some of these dilemmas and charting a way forward that does challenge power structures, but is also pragmatic and viable, because I think that becomes a price one pays for being perhaps too idealistic or too principled in promoting community action for health. The last thing I just wanted to say is, in so doing, one may need to acknowledge that whether it is community-based monitoring, village health and sanitation committees, even community-based insurance, our ASHA program, all of this is labor, right? And if you're expecting communities, especially communities facing disadvantage, to participate, you have to pay for their labor. You have to do wage replacement, you have to pay for childcare, you have to pay for people to be there. And I think, again, we have this sort of, again, wandering into idealism around community voice and so on, but really in the doing of it, there is labor, and I just wanted to underscore that.
Thank you. Somesh, I'm just going to let you pick up from there in the hopes of having this be it's great. In the hopes of having this be a conversation between all of us, maybe with a bit of focus at what's happening at the national level, but feel free to pick up on any thread that makes sense to you. Yeah.
Thank you, Svea. So at the national level, I think Dr. Kotwal talked about a lot of national level initiatives, and Rajni touched upon it too. So not repeating, I'll take probably a more different thread here and think about it more conceptually for a second, and disconnecting ourselves a bit here of what actually is happening, and we are talking about just what is happening and what should happen better for, and it's not all is abstract though, but think about health as not only service delivery, but health also as an outcome of the social determinants, right? And so we all realize that the communities which are vulnerable and have been excluded in all the welfare programs or the development of the society as a whole, they have been left out in lot of these interventions and programs, and they are most disadvantaged in terms of the social determinants of health. So talk it about drinking water, sanitation, access to latrines, even basic health awareness. And so this plays disproportionately when we talk about primary health care and the health outcomes of these communities. So I think for us, as we think about healthcare delivery and reaching these communities through our programs and systems, we should also think about how do we address the social determinants of health in a much more equitable and definitive manner that will bring about a more basal improvement in the level of the health status that they have. And how do you do that? And WHO in its framework has talked about it in the third pillar of primary health care, and their strategy is multi-sectoral convergence for doing that, right? And so for us, most of us are working directly with health systems. It behooves us to think about, are we engaging enough with the other departments to make sure that these social determinants of health are taken care of. As we speak today, there is a Panchayati Raj Institution conference happening in Tirupati by the PRI division of Government of India. And there is a statement made there by the secretary, data, that there are 250,000 panchayats. That's a big village kind of a thing in India. Only 5% of these, that's around 13,000, have something equivalent to a health priority plan for themselves. So again, it's probably a huge missed opportunity, because equity and inclusion is by definition a very decentralized concept. You can achieve coverage by high-level policies, but decentralization has to happen by local participation, by non-health departments engagement. So PRI is one. The other one. So talking about other convergence with other departments, that's a strategy that we should think about more deeply. It's a very hard space. None of us have been able to crack it for obvious reasons, but I think it should not be left aside for this very reason. Since it is hard to crack, I think a lot of equitable and inclusive healthcare or other health outcome will happen by more definitive focus on social determinants of health and how we can improve. And second, quickly, again, Dr. Kotwal talked about the institutional structures of jazz, and there is a huge potential there now, coming more proximal to health system. So there is huge potential there. Half of these committee members are women. 1/3 are supposed to belong to vulnerable communities, whether it's tribal or youth, more indigenous in some cases, and loose for definition. People can do it for themselves, migrant population. So investing in this capacity of these mechanisms that have already been created, which is much more in control of the health system, can help in the short term. So two threads of conversation. One is around the social determinants of health, and then what is actually happening through the health system. How can we invest more energy and time in that space?
Well, I have lots and lots of questions, but Harsha, I'm going to ask you to keep me on time as well. You can. But I want to make sure that people in the audience who have burning questions we can start with those, and then maybe I can slide some of mine in along the way as well. And if any of you have questions you'd like to ask each other, please do that as well. Is there any burning questions in the audience, or is everyone really tired after a long day? Yeah, Shalini.
Thank you, panel members. Devaki, my question is to you. Very simple. I just want to learn a little bit more about this Delhi Declaration. Like, how did it come into being? Who were the members? And like, is it feeding into policy, or is it just an activist declaration?
So space issue. So Shalini, this is, speaking of abstract, this is the regional committee of the Southeast Asia region, the WHO Southeast Asia region. So this is a meeting where all the member states of the region come together, they send their official representatives, and you agree upon this politically correct language. It's very well thought through, frankly. But it's quite abstract, as you saw, right? And this, there has to be member state consensus as per WHO sort of procedures, and then it's kind of put out. There are a number of declarations. There's probably a declaration every year with the regional committee meeting. To what extent do we feel this can guide what happens in country? I mean, I think it gives, it's that normative value that WHO perhaps brings and member state consensus documents bring to the process. But, you know, where the real work is, the nitty gritty, it hasn't really done that. But then there's some technical documents that coming out of HQ, like there's a handbook on social participation for health that came out, I think in 21 or 22, 21 probably, that has a lot of case studies and some of those kinds of things. And really, there needs to be a lot more research, I would say, in this area that would be actually perhaps more helpful for the kind of thing we're talking about.
Yeah, for the Delhi Declaration on primary health care. So we were there in Sri Lanka, I think you were also there for that. So there was an initial consultation among all the states. And prior to that, there was a specific focus on human resource for health too. And NSRC was involved in the final drafting and all of that, which of course Ministry of Health submitted it. And you're right, a lot of provisions had to be dropped because some state didn't agree on one thing, another state, member state did not agree on another thing. But anyway, there's a declaration. There is some roadmap which is there, and we could add lot of such issues of community and processes and social determinants of health also. So, but again, yes, happy to learn more that how it could have been improved, so that next round we can give our inputs to ministry that probably these could be included or not.
What can you expect of a declaration, right? Some of these are consensus documents and they play their role, and then there are other kinds of outputs that play different roles.
Thank you. Thanks to the panelists for sharing their views and Svea for moderating. I had a question around vulnerable populations. Some of our interactions with communities in Meghalaya, which have, I would say, some challenge in some public health systems, especially primary health care, and interactions with the communities have shown that they trust the local healers more, and that's where their trust stays. And there have been some initiatives in trying to train local healers so that they are the ones who then provide, who can then provide primary health care. I just wanted to just sort of throw that out here to the panelists, whoever would want to take that, and what your view might be on this. And it's not just the Northeast, but it's other parts of India as well. Thank you.
See, it's a tricky one because even I come from Bihar, Darbhanga, which is one of the underdeveloped states. In my village, still after a lot of investments from government, my quasi-doctor, right, who has been practicing for last 20-25 years, is still the most sought after person for healthcare. It is still there. Now there have been movements of quasi or rather preventative care being taken from the health and wellness centers and the lot of maternal health services from ANMs and ASHAs reaching out for lot of RHFPRH services, but this guy still has a lot of practice going on. So how do you engage? This was a question I was asking myself. I don't have an answer. I don't think lot of us have an answer, but one way to do this is engaging with these guys as again the link between the health system, formal health system, and the community. These guys are there. Remember, if there's 11 o'clock, there is something very acute that happens. The additional primary health care centers and PHCs are not working. So the communities, even my extended family would go to this guy, and because there is trust there. So while the formal health system cannot engage them for delivery of service, I don't prescribe to that view, but as more for the link between the society and the formal health system, we have to start engaging them where this is still a very important part of the healthcare delivery. That's my take on it.
I have sort of dated research on this, Madhavi. So Kabir had led a piece of work in 2011 where we looked at integration And in the case of Meghalaya in particular, it was not just these Ayush systems, which are of course critical, and perhaps their use may be waning to some extent, but they're still a critical part of the sort of fabric of around health and society. And if you recall in NRHM, there is this idea of mainstreaming Ayush and revitalizing local health traditions. And there is this sort of mourning of their loss and thinking about their, their dying, and et cetera, and so on. So following this in 2014-15, a group of us did a bit of research, ethnographic health systems ethnography. It was not in the Northeast, which is, I think, a unique context. But in the South, we saw that there are a couple of issues. One is that what's called the problem of light OT. We have some publications on this. The fact that local health traditions are seen as not this, not that, not this, not that, right, and are not recognized as a fairly wide and complex set of practices and systems. In fact, Siddha is the precursor to a lot of medicine that's practiced in Tamil Nadu, for example, right? And a lot of Siddha practice comes from Marma Vaidya, which is a local health tradition, things like that. So I think understanding these lineages and these complexities needs to be done. There's variation in Meghalaya as well, and it's a bit problematic to sort of group them together. I think for policy reasons one tries to do that, like you do with NCDs, right? So we've all talked about the problem with that. Anyway, so that's one. I think the other thing is with the existence and the trust, as Somesh was talking about, that is reposed in these providers, really, right? There is, again, a kind of dilemma to me between the conflation on the one hand of these providers as all being quacks, because they're not. And we've written about this. On the one hand, and second, just seeing how to leverage that trust, but trying not to do it in an instrumental way. Because we had, I think this was in January of 2016 or 17, with the Vaidyas from Tamil Nadu, Kerala and Karnataka, we had a meeting where they sat face to face with people from government. And it was one of the first times that had even happened. So it's always this sort of instrumental thing that we do with a lot of providers and workers in the system, where it's like, we can use them for this, we can use them for that. And I think they want to help with some of these things, but I think the modes of engagement with these actors has to be more respectful, has to be more mindful that they're not all quacks, and certainly there are quacks also. So it has to be careful and meaningful in that way. And I think in many cases, a lot of the healers that we spoke to are very interested in this patient navigation function. They're quite clear about what they don't do, right? And these are the ones who are not quacks, again, right? And so I think engaging with them is very important and can lead to this trajectory. This trajectory of them helping provide the services that they do and connect in cases where they don't, right? Being recognized by the system as such.
Thank you.
Sarah had a question?
Can I add a point before we go to the next question?
Yes.
Great. Okay. Thank you. I think also, I believe those are all really excellent points, and this is been something I think in primary healthcare we grappled with across the world for a number of decades. I think, in recent years at least, as we look towards more urbanization, and also as we have reasons, to really want to engage with youth more as well, whether it's for things like HPV vaccines or sort of mental health support, working, to support them to not feel isolated during periods like COVID in particular, but more generally, but also there are some bigger dynamics with the changing workforce that I think we're grappling with in terms of reaching sort of underprivileged or sort of under-sought out subpopulations. And I think what we're also seeing is that in addition to demand to see local practitioners that communities know very well, that there's also this perspective of, well, we just want to see a doctor. We don't want to see a community health worker. We don't want to see a nurse. We don't want to see, whoever. We want to see a doctor. And of course, there are many complexities with that in terms of access, in terms of health workers, in terms of
many challenges. And so I think just to also note those, particularly as we look towards the future, I think that those kinds of dynamics will continue to be bigger issues that we're to grapple with. Thank you.
Great, thanks.
Thank you very much. I wanted to explore a little bit the arguments around funding and community engagement, and you brought it up, Devaki, and I think that Rajani, Dr. Ved did as well before the in the previous panel. And it seems to me that even for our frontline health workers who are volunteers, ASHAs, there's not the kind of remuneration that you might hope for the roles that they do. But it seems to me to be particularly difficult to support funding for community engagement, where you're really trying to get communities to hold the health system accountable. And particularly to get that funding coming from government to stimulate that kind of accountability. Because holding people accountable for their actions is always a difficult process, and a process full of tension often. And I wonder if it's the right thing to be looking at government to support that, or whether we should really be thinking about other ways of supporting that kind of financing.
And I'm going to piggyback on that question, because that was in my mind as well, and ask what's the role of those of us in this room in that process as well. I mean, facilitation was mentioned earlier, several times earlier today as well, as an important piece. And what role do organizations like WHO or JHPIEGO or researchers have in that process? So sorry, Sarah, to Meike, they're trying to make you go first.
Okay, I didn't hear what Devaki said, so sorry, I'm a little bit out of the loop. But I'm happy to make a few comments. Yeah, I mean, I think it's a big challenge. I think one of the things that we're challenging ourselves at the Alliance, and also that I think the special program on PHC at WHO is really aware of, is that if there isn't practical, actionable evidence of the sort of impact or the value of these processes, then it's going to be really hard to make that case. And I think that evidence has been sort of scattered and mixed and complex and maybe not so easy to sort of find and get hold of, and also have sort of at scale and in a form that makes a strong argument for decision making. At the same time, I think that what we've seen over and over with community engagement, and I think why it continues to have such a central place in primary healthcare discourse as sort of a fundamental concept, as an aspiration, is that when it's working and when decision makers are listening to communities, and the communities do have spaces where they feel like they're being heard, that there's an incredible amount of sort of internal resources that communities can sort of galvanize and guide towards whatever their objectives are. And so I think to Devaki's point, obviously it's very important to recognize that we're not exploiting that community energy, but I think that some of these functions don't necessarily need to have don't require necessarily a huge amount of financial support if they're perceived as valuable from the community side. And I think it sits with as a sort of an obligation or a responsibility of all of us, certainly from the WHO side, to provide, continue to contribute to the evidence of what is working and how to facilitate that. Communities do really feel that they have agency and that they are valued, and if they invest their time and energy, that it's worth something. Decision makers can see the impact of that. And that we will conduct research, seek out opportunities to do research, and we will package those findings in a way that are practical and useful for other stakeholders. Thank you.
Okay, yeah, so, so if I understood the question from you, it was how do you, as organizations like us, facilitate community, more community engagement. See, I think community engagement will need rightly more resources, both funding as well as more capacity building, and it should not be one another element of a huge program where you are focusing most of your attention on the 12 service packages, bringing the community health officer, the drugs and diagnostics, and community engagement, right? So, and so majority, if you see the funding, and I mean, I'm not asking that there should be disproportionate amount of funding, but there should be funding to make this effort more accountable. If you mean, you know, if there's money, there's more in accountability tied to it somehow. So I think for what we are trying to do in our very limited sphere of influence through our programs is one, through the program that we are doing together, learning how do we operationalize jazz in the most effective manner, and what are the learnings from there. You know, how do you choose these members from the vulnerable communities, and how do you then, what are the then key threats that come out that can then be brought to the national level for more replication, etc. So those are kind of more learning things. In addition to that, more like tactically, what we have done in Jharkhand and in some other places is operationalizing the IVRS feedback from the community. So something like a Mera Aspatal, which is a feedback system, is getting institutionalized by the government, and as it was taking shape. Before that, we had partnered with a group called Gram, and we had designed something in consultation with or in partnership with the government of Jharkhand about the IVRS mechanism, where the phones would go to the users of the healthcare in primary healthcare centers, and they would then be asked to give their feedback. And so but ours is more tactical. You know, the strategic push is something that needs to come from more from a governance and more program level, policy level.
Maybe starting to speak to that a bit, Somesh, and trying to link to the point you raised, Sarah. I think that this issue of funding, you know, if the government is not to fund community action or social participation, then who is? Particularly in country contexts where civil society fundraising and civil society organizing or support or other kinds of fundraising, other sources of funds are viewed with suspicion, and that's the case in many of the countries of our region, right? So that to me is one of the walls that you run into when you think about other types of funding. And I think relatedly, there is a need to kind of understand, and Dr. Rajni was talking about this earlier also, institutional design a bit better, and perhaps that's where we come in. So for example, in Thailand, you know, the national health assemblies are funded by this National Health Security Office, I think that NHSO, and a lot of that advocacy sits there. It has its own sort of funding stream and so on, and a level of autonomy. You compare that, for instance, to the national health, the state health assemblies, the district health assemblies, and the block health assemblies held in Tamil Nadu with World Bank funding, right? That was a different institutional design, and you know, what is the sort of process of that? What is the yield of that? What is the sort of scalability? You know, there's usually short-term successes, but then how does that play? And who's involved, right? What works for whom? So we're actually embarking March onwards on a sort of realist approach to kind of start to understand this within India with various forms of community action for health. But my appeal would be to groups like this to really help unpack that using a sort of institutional design kind of lens to get to that strategy piece, Somesh, that you were talking about, alongside the actual programmatic on the ground piece that you're doing, you know.
Thanks. We've got lots of questions and maybe a bit of time. How much time do we have? 10 minutes. Okay, great. So Zabir has a question.
fascinating discussion. And I was just thinking about, like, when you're talking about a community engagement as an invited space, what can be an alternative way to talk about maybe collective governance, like community level collective governance, whatever. But I just wanted to, I wholeheartedly believe in community participation, but I was thinking about, should we think about the justice and equity part of it, where we are asking the community to collectively govern when it's a right to get health care, and are we de-shouldering the government's responsibility to ensure that kind of a participation and transparency and accountability towards the community when the community is already vulnerable, and asking the marginalized people to take on additional work. And that's, I'm just thinking about when NRHM in like early 2000 and last 20 years, this big push of community engagement happening, and how we are actually like looking forward in the future, that from the perspective of like justice and equity. I'm not sure if I make sense or not, but just what's your thought? Like, not any kind of a specific person, but what's the general thought in the room?
Devaki hands the mic always to me, but you can always speak. These are very hard questions. I don't think we are, but maybe
No answers at all. But I was trying to link back to what Sarah said about who should be funding community processes. First of all, it's quite problematic, even though I've been part of this whole process, to put accountability as the key indicator of community participation. That's clearly.
My is not working.
Now it is. Okay. So, no, I just said I find it a little problematic to have accountability as a big indicator of community participation, right? Community monitoring for health. Why should and as he said, there are vulnerable communities and you're putting this additional burden on them. And this is a tricky question. Who supports building community capacity, collective capability, and facilitates that process? And I think we tried in India through that whole community action for health to get NGOs which were removed from government in that sense. They were autonomous. Even the institution that held this funding together that came from government was removed from government. They had one member of government on the board, but that was completely overseen by NGOs. And had it got support, it did move along for 7 years and then, it lost support and the whole thing fell apart. But I think, and we have another example in India's employment guarantee scheme, where by law, they have something called the social audit, which is a separate funding stream that the government has. They have independent auditors who go out and see whether people really got the money they were promised. And that's it, created by law, funded by government. So I don't see the harm in being funded by government, but it has to be completely autonomous, independent, and citizens have to have right over that. I think that may be a way.
Yeah, Shani.
Based on the work that we've been doing like last 8 to 9 months about this, social accountability and everything, I used to find it very glamorous and very attractive to work on. But trust me, like when I have been working with the panchayats, with the community members, with the health and wellness centers provider, there's such a nice organic relationship just emerging, and we'll just go there and ask community members, now you hold them accountable. So, there's also this thing about, there's a trust. They struggled, all these CHOs have struggled last so many years to build that relationship, and suddenly, with this top-down messaging about like, okay, now you need to monitor these CHOs, now you need to monitor these health and wellness centers. I am kind of a little skeptic that what kind of outcomes, or are we actually spoiling something which has just started to begin?
Oh, sorry, these were comments. But reactionary comment from me. I think one of the things, Dr. Rajni, that I was thinking about, AGCA for instance, it has this autonomy, but where does its funding come from? Did it used to come from? And who else could fund AGCA? How would that even work if it came from somewhere else, right? So that core issue of where is that money coming from I think we're still demanding that it comes from the government, right? Yeah, so they pool it and bring it in, right? So, yeah, I mean, I also don't really have answers to that. But I think the other thing that I wanted to signal is that whether it's community action for health, community engagement, or even our efforts, a lot of us are researchers. When we try to do participatory action research or community-based research, we are quite often dealing with partners or colleagues on the ground who represent communities, who have severe time poverty, who face various kinds of disadvantage. So this is not totally unlike that scenario where you're expecting someone to be a community researcher, or to come and participate in your research study and care about it and all of these things, where they're talking about their life concerns, right? So this is not something that's unique to just this sort of issue area. It's fundamental to the conduct of research, and I think something that we're all really struggling with. Again, there are some indications or suggested things around best practices there, but that's another kind of thing, to create learning spaces where we can think about just how to be more ethical with some of these pieces in research and in implementation.
One quick comment. Going back to what I had started on the equity and inclusion in primary health care. One another structural lever that potentially, and this is not evidence based, but based on my program and policy learnings that I've seen across health and non-health, more non-health, is for equity and inclusion. I think there is, I've seen more of it happening when there is more funding and power to the locally elected governments. So again, I'll take example of my village, going back to 20 years ago and today. You will have a road or a brick path, footpath, on to every household almost, even to the 5 household which was away from the village of a separate caste or something. And I asked this question, why is this happening? And this is and the answers in some cases have been, that the village health committee equivalent, the panchayat committee that is there, that has a ward member from that group. And that is another realization that I had. These guys are also these 5 people, 5 houses of one community which was kind of looked as vulnerable, downtrodden, whatever. They never had this. Now the government is putting it, and it is putting it because there was a ward member elected by this group, which is now sitting there in that funding decision for that village. And it's not so giving more health funding, quote unquote, to some of these locally governed bodies, elected governed bodies, can be another structural strategy that the government is already thinking about. In the recent 15th Finance Commission, they have deployed a lot of money for primary health care, diagnostics, etc. within the 15th Finance Commission. But then the hairy part is, how do you build capacities of these groups to make best utilization of money. But the long term, and this is my take, with a bit of passion, but the long term, that is the most definitive route for these 5 houses to get the health care that they want, because that is how it will come eventually. In the short term, there will be more pilferage, less effective utilization, less evidence-based decision making. In the long term, that's how other departments are doing and doing much better than health as far as equity and inclusion are concerned.
We've got just maybe a couple minutes left. Mike, I don't know if you have any final words. No pressure for you to have them.
Sure. No, it's a great discussion, and I think these are really hard questions. And I think maybe just building on what a number of colleagues have brought up, such good points, and just maybe a reflection back on all of us again, whether it's WHO or colleagues that are working within the healthcare system in India or elsewhere, as well as researchers, is that, I think oftentimes, and this is part of, has ethical ramifications, it has resource allocation ramifications, as well as many other aspects, is that I think we do often tend to come to communities and say, okay, we want to improve your primary healthcare service access, or we want to work on how we can use digital solutions to help you, or we want your input on this particular topic, and those our ideas about what is important or what we would like to know from communities, or what we think, how we think we might be able to help communities, doesn't always align very well with what community priorities are. And so I think that as a bigger picture, really trying to find better ways of how we can link communities with those resources that they want. We can provide flexibility with the resources that are allocated at the local level to be able to really address community needs, and also to allow for, or deliberately create space, and also really take seriously and respect the feedback that we're getting from communities about what's really important to them. I think it's at the crux of being able to move forward with broader health agendas, to be ethical, and to being able to really better understand how we can make these community platforms and functions work better. Thank you.
Well, that's a great place to stop. Thank you so much to our panelists. Really, really appreciate it. And to all of you for staying engaged through this long day. I have a note that we will now break for cocktails and dinner, which sounds lovely. So thank you all so much, and look forward to continuing the conversation.